Hello, and welcome to an evidence-based practice presentation revolving around COPD, chronic obstructive pulmonary disease. My name is Shannon Carney, and my role for the next little bit is to share some information with the listeners about this relevant disease. So, why COPD? This topic pulls my interest due to its prevalence. COPD is the fourth leading cause of death globally. This disease is expected to steadily increase due to the incidence of smoking within the aging population. The WHO predicts that COPD will be the third leading cause of death by 2030. Estimates have also been made for 2030 that COPD will become the seventh leading cause of disability-adjusted life years. This disease has also made itself an economic burden. In 2010, COPD accounted for $49.9 billion in direct healthcare expenses. In Australia, that number was $98 billion. Just imagine how much that number has risen within those last 11 years. With newer and popular trends that revolve around smoke inhalation, such as vaping and juuling, it is expected for there to be a drastic increase in COPD cases in the future, as these young adults and adolescents are not properly educated on the severity and the risks. The patient I cared for with COPD was a current smoker, as well as her spouse. Smoking cessation is by far the highest priority with this disease. This presentation will talk on behalf of COPD, including what it is, what happens, and how to handle this severe yet treatable disease. The patient that I took care of was a 74-year-old Caucasian female who is slightly overweight. She uses a cane and is a standby assist. She was brought to the emergency department by her husband with complaints of short of breath, dyspnea, lightheadedness, and an overly productive, very mucousy cough, just more than normal. She was admitted to the cardiac step-down floor with a diagnosis of acute exacerbation of COPD. Her medical history consists of COPD, of course, osteoporosis, depression, smoking, and coronary heart disease. Upon assessment, she was alert and oriented. She was short of breath on exertion. She was wheezing, showed barrel chest. Her skin was intact with no wounds, and she is on 2 liters of nasal cannula. Significant lab values include a CO2 level of 47, blood pH of 736, hematocrit of 32.7, and a hemoglobin of 10.8, so her blood was very acidic. A few medications include prednisone, which is a corticosteroid. This is an anti-inflammatory for the airways and the lungs during these exacerbations. Methotrexate, which is a relaxation of bronchial smooth muscles resulting in bronchodilation. And lastly, a long-acting beta antagonist, which relaxes the airways smooth muscle. So, overview of the monograph. What is COPD? The authors strictly define this disease as a progressive and persistent airflow limitation associated with an amplified inflammatory response within the airways and the lungs, which is in response to chronic irritants. Those chronic irritants being cigarette smoke, the noxious particles, gases, and air pollution. Specifically, during exhalation, airflow becomes significantly reduced due to the combination of inflammation, fibrosis, and exudates within the airways. This buildup will trap air and not allow the alveoli to completely empty. Therefore, the patient is unable to return to baseline functional residual capacity in order to meet basic metabolic needs. This hyperinflation reduces inspiratory capacity, leaving the patient with impaired gas exchange due to an imbalance of ventilation and perfusion. An acute exacerbation of COPD is worsening dyspnea, cough, and or sputum beyond the patient, what they typically experience on a day-to-day basis. My patient's acute exacerbation stemmed from her smoking habits as well as her spouse and living in that just smoky home because they do choose to smoke inside. So today's treatment. Inhaler therapy is the mainstay treatment for COPD patients. These medications typically consist of a long-acting beta agonist, long-acting muscarinic antagonist, and an inhaled corticosteroid. Oxygen within the hospital is essential, especially if hypoxemia is present. Oxygen levels should be greater than 90%, and oxygen is to never be withheld from these patients. Bronchodilators can be administered via metered dose inhaler or a wet nebulizer. This monograph does a great job reinforcing that importance of smoking cessation, because that is the #1 leading cause. The 2 pieces of literature I selected were rich with information with aim towards simply how to better the lives of these COPD patients, starting with their medication regimen and successful self-treatment. I'll begin with discussing the left side. The title is Long-Acting Mucinogenic Antagonist plus Long-Acting Beta Agonist versus Long-Acting Beta Agonist plus Inhaled Corticosteroids for Stable COPD Patients. For this presentation, I'm going to refer to those as LAMA and LABA, also ICS. This is a level 1 evidence from a systematic review or meta-analysis of all relevant randomized controlled trials. The Global Initiative for Chronic Obstructive Disease Recommendations for COPD Medication Combination, they updated it and they made these researchers think. Their objective was to compare the benefits and the harms of LAMA plus LABA versus LABA plus ICS for treatment in people with stable COPD. The groups included individual randomized controlled trials, parallel group trials, and crossover trials, comparing the possible medication combinations, so either LABA with LAMA or LABA with an ICS. There were 9,839 participants, as the trial duration lasted 1 month and was held in an outpatient setting. They were able to conclude that LABA plus a LAMA result in fewer exacerbations, lower risk of pneumonia, fewer flare-ups, and an improved quality of life, and just a better overall quality of their lungs. My patient uses a long-acting beta along with the ICS, the inhaled corticosteroid medication combination, and that might add to the reason why she's been experiencing these frequent exacerbations and just has this poor lung quality after all this time. So that brings us to the right side, and this is titled Action Plans with Brief Patient Education for Exacerbations of COPD. Also a level 1 evidence-based clinical practice guidelines based on systematic reviews of the random controlled trials. So self-management is most important, is the most important responsibility for living with COPD. However, that's very hard to correctly do when you were never properly educated. An action plan includes interventions designed to assist patients while at home, for example, how to recognize and initiate early treatment of COPD exacerbations. These researchers compared effects of the use of an action plan with, and while they provided a single short patient education component versus usual care. In this trial, there were 1,550 total participants, with 66% being male. The mean age was 68 years old, and 20% of the total participants were current smokers. Once the 12-month mark was up, data revealed that patient action plans resulted in fewer ED visits and hospital stays related to breathing problems. Those with an action plan took more corticosteroids and antibiotics for their COPD exacerbations, as well as recognized worsening symptoms right away and was able to treat those symptoms. My patient admitted to not being as educated with COPD as she would like to be, so I was able to take that as an opportunity to speak with her about these exacerbations in regards to what they feel like, how she knows that it's happening, how to treat it, and when to know to arrive to the emergency department. This monograph listed many recommendations in each category. The ones that I chose to highlight definitely connect with the patient that I worked with, and all these recommendations were utilized within caring for her. Under assessment, it is recommended to recognize key signs of worsening exacerbation, such as use of accessory muscles, retractions, nasal flaring, and reduced level of consciousness or somnolence. For data analysis, it is recommended that pulse oximetry is not a substitute for arterial blood measurements of CO2 and pH because they may not correlate to the symptom distress. While planning and implementing care, it is encouraged to teach patients the tripod position and pursed lip breathing, which will reduce the work of breathing and calorie and oxygen consumption. While working on discharge planning, remember to develop and present to the patient an action plan that addresses self-management for COPD exacerbations, including a decrease in dyspnea. The patient accomplished a better understanding of her exacerbations and why they kept happening. More importantly, she was able to verbally reiterate the risks and useful benefits, and she also was able to teach it back to me. The patient also accomplished breathing on room air without her oxygen levels dropping below 90. And she said that is thanks to her tripod position and her pursed lip breathing. So, what did this patient benefit from all this? Let's start off with learning the warning signs of an exacerbation, which include coughing, wheezing, short of breath more than normal, and any changes in mucus production. Instead of ignoring signs of an exacerbation, the patient now benefits from being able to recognize those signs and begin early initiation of treatment. Mosby's monograph laid out the criteria for admission, which benefits the patient to know what is happening so that early treatment can start. No more waiting until it's too late to be seen. Smoking cessation was heavily touched on with this client. As I mentioned prior, her and her husband are current smokers who also both smoke inside the home. However, the patient explained how she would definitely like to stop smoking, and her first priority is to turn their home into a smoke-free environment. Lastly, the patient benefited from becoming familiar with the basic pathophysiology of COPD. It is important to understand why COPD takes place and what's actually going on within your body in order to prevent worsening of symptoms and fewer exacerbations. In conclusion, COPD is a common disease that is treatable and has the ability to be successfully self-managed. Self-management includes smoking cessation, medication adherence, a healthy diet, controlled breathing, and recognizing early signs of exacerbations. Smoking is more prevalent than ever nowadays, with juuling and vaping, especially throughout young adults and the adolescents. Early education on effects of smoking for younger patients is just as important for the same education for our older patients. It has been shown that a long-acting beta agonist paired with a long-acting muscarinic antagonist results in fewer hospitalizations, exacerbations, and improves overall quality of life. To further aid in bettering one's quality of life, an action plan would be beneficial for the patient in prevention of future readmissions, facing complications, and worsening of symptoms. It is possible for COPD patients to live a happy and healthy life, but that starts with us, the nurses. It's our duty to make sure that our patients are competent and well-knowledged in order to take care of themselves comfortably and successfully. There are just too many benefits from an extra 10 minutes of teaching and one-on-one time between the nurse and patient. It could save them their life. Thank you, and I hope you learned something about COPD that you're able to take with you when we are out in the field.